very good morning to you. I'm Howard Feldman. This is your Sunday podcast, courtesy of Synthesis Technologies. As we have done every Sunday, this is in fact our 7th podcast, I chat to Dr. Anton Meyberg. He is a pulmonologist physician in private practice. He is a COVID-19 expert and is at the forefront of fighting this disease here in South Africa. You send us questions, we answer them to the best of our ability, or certainly Dr. Meyberg answers them to the best of his ability. And every week, and that's what's been so interesting, the nature of the questions have evolved. It is Sunday, the 26th of April, and we're a lot different to where we were a short 7 weeks ago. Dr. Meyberg, a very good morning to you. How are you?
Good morning, and thank you for having me again. It's good to be back. We are currently sitting on 2,923,000 cases worldwide, with 203,000 deaths. The United States are leading the pack on 960,000 cases with 54,000 deaths. South Africa are sitting on 4,361 cases with 86 deaths. At the moment, there have been 161,000 cases tested in South Africa, and we're ramping up our testing quite dramatically, doing 8,000 to 10,000 tests a day, although this is still not enough.
Is it likely that we are going to get to the 30,000 a day that the Minister has been speaking about?
Not only is it likely, but it's extremely necessary. We need to ramp up the numbers dramatically.
So do you think do we have the capacity to get there?
I think we're going to. I think we are going to get there.
Okay, that's great. That is, and of course, the president made the announcement on Thursday evening about the different levels that we are now going to be designated in terms of 5 levels. We are currently sitting at level 5. From Friday morning, this coming Friday, we're going to go down to level 4. A lot of people are asking your view on A, what do you think about these classifications? And B, do you think that we are actually ready to go to level 4 from a purely COVID perspective?
So, first of all, as I've said, I'm a big fan of the president, and I'm a big fan of Israel and Kizzy at the moment. They're doing an excellent job. I do think we are ready to go to level 4 at the moment. What we've got to do is we've got to develop something called pandemic resilience. And that's basically a massive upscaling of our testing. And if people come back as positive, they need to be self-isolated. In the interim, we have got an economic instability and the economy is completely flat. We have no choice but to go back to work, okay? But what the president has done is that 1/3 of the current workforce that is in necessary workforce can go back to work. And I think that's right. But they've got to test their workforce on a daily basis. They've got to make sure that they don't have a temperature, they don't have symptoms, and send them home. And people can't take advantage of this saying, well, I think I'm a necessary requirement to go be at work and I should be at work. It's got to be the necessary skilled people that for those skills and those tasks that are needed to be done. So I do believe that it's a good idea that he has down the level from level 5 to level 4. I do hope we don't go back up to level 5 after a while, but we have to upscale our testing in order to keep this going forward.
One of the things that certainly I've seen and I've heard from a number of people is the amount of time that it's taking to fill in forms and the delay around documentation and capturing of information. Have you seen that as a problem?
Regarding testing or regarding general?
Yeah, one of the major retailers that I spoke to said that they want to test their staff at least once a week to make sure that they are COVID free. But
that would be wonderful. It really be wonderful if you could test your staff once a week, but it's not practical. So we don't have enough tests for that yet. So with all due respect, if it takes a long time to do the test, what else are you actually doing at the moment that you can't write for a few extra minutes to write your details down? So I don't think it's a major problem.
Right. Okay. Fair enough. Let's look at some of, and we're going to come back towards the end of the podcast. I do want to come back to talk about what it means to go back to work and what is normal and what is not normal in this environment. Because, whereas OCDs might be thriving right now with all the hand washing, if we need to have some measure of what is reasonable and what is not reasonable. But we will come back to that. Let's take a look at some of the questions that have been put to us. Selman wants to know, he listens in from Israel, and he says, if somebody is in ICU and they are doing particularly badly, are we throwing all of the experimental drugs at them to test to see what works and what doesn't work? And if not, why not?
So that's a very good question. And one of the reasons I can say why not is due to a medical aid problem or due to a funding problem. Remember, these are all non-peer-reviewed treatments. Nothing has been stipulated by the FDA, the Drug Administration, or the Center for Disease Control. These are all drugs that we believe can help. We postulate they can help, but none of them have been proven to help in a way that any major medical aids will fund the drugs. So if you take some of these major drugs, and obviously life is priceless and you can't put a price on life, but the reality is that if there are two people with kids and one of the husbands, let's say, got put in hospital and he's on all these treatments and the person dies and the medical aid doesn't pay for the treatments, you could be looking at 500,000 to 1.5 million rands of debt. And you've got a young wife, young kids, and how are they supposed to pay for that type of thing? So obviously we'd like to throw everything at every patient, but we've got to take it as per individual requirement and need. And we've also got to see what the patient presents with. Have they got diffuse ARDS, which is the acute respiratory distress syndrome? Have they got this pro-inflammatory state with this cytokine release storm that they need all these drugs? And are the drugs validated and necessary at that point in time?
And it's also interesting in that I would imagine when a person's in that kind of a state, you're not just dealing with a virus, you're dealing with every other factor of their body.
So at that stage, you're dealing with what we call a MODS, which is a multi-organ dysfunction. Not only is the lungs collapsing, not only is the heart collapsing, the kidneys are collapsing, the bone marrow is collapsing. So you've got a multitude of problems you're dealing with, and it's not only those drugs that can help with those type of things. You're looking at things like dialysis being necessary. You're looking at cardiac intervention. You're looking at things that down the line that might be necessary, things like ECMO. There's lots of things that might be necessary and could be necessary, but we just don't know.
A couple of questions about I'm trying to understand pre-existing conditions and comorbidities. If somebody has hypertension, if they have high blood pressure, which is controlled through medication, in other words, their blood pressure is normal, are they still at higher risk? So
we've always put out that people with comorbidities are at high risk, but I think we've got to explain that a bit better and say that if you are 50 years old and you've got high blood pressure and you're on one blood pressure agent, you're okay. The problem is if you get the virus, then you're at a higher risk of getting sicker. And that's what we've got to say. So if you're over 65 with multiple conditions, you're at a higher risk of getting much sicker than a 40-year-old who would have the virus, who's got no comorbidities and wouldn't get as sick as you.
Right. Okay. So, so the answer is that you're not at risk, at high risk for getting the disease, but even if you do have hypertension, which is controlled, you are at risk for getting sicker if you have if you get.
You see, generally people with high blood pressure over the age of 50, then they've got other issues, and they could have coronary artery disease, and they could have more of a risk for strokes and more of a risk for myocardial infarctions. That's the risk that you're dealing with as well.
Right. Okay. Taking a look at further questions. COVID patients, this is from Carla. COVID patients that are put on ventilators have a low survival rate. She says 34. I don't know if that's accurate or not. How far is South Africa in the trials and testing of drugs like hydrochloroquine? Hydroxy, you pronounce it. I'm not even going to try.
The drug is hydrochloroquine. Okay. We are using these drugs, as I said, in last week and the week before, things. These are not peer-reviewed drugs, and we've got to be very, very careful. These are drugs that a cohort of doctors all over the world are trying. All these drugs have got side effects. And even back to Selwyn's question, they've all got side effects. So if you take drugs like hydrochloroquine and azithromycin, which are being used in combination, all these things can do is they can cause an increase in your QT prolongation, which is a cardiac abnormality on your ECG, which can be a serious side effect and cause death. So all drugs have got side effects, and every person has got to be looked at as an individual and see what their comorbidities are and checked on a daily basis to see if they've got other problems. With regards to the ventilators and those being on a ventilator with 34%, the person who goes on the ventilator is extremely ill. We try to avoid ventilators at every cost. We try to do other types of treatment. We try to prone the patient, we put them on their stomach, and we try to get rid of the fluid from their lungs. We try to do what we call high flow oxygen, which is a high flow of oxygen to the nasal cavity. But when you do go onto the ventilator, you are extremely ill. And a large proportion of those patients do not come off the ventilator. So putting someone on a ventilator doesn't mean they're going to get better. It's at that stage where they're extremely hypoxic, they're not getting oxygen into their lungs, and that's when they're in multi-organ dysfunction and are extremely ill. So they've got a much higher chance of not pulling through. Right.
Wendy wants to know, and Danny asks a similar question. Wendy says, can one still contract COVID-19 by walking in the streets, with no social interaction and not stopping to talk to anyone? Danny also says, can you ask how exercise now looks like it'll be allowed soon? How far should you be from other runners? Can you be in their slipstream, even if it's 5 meters behind, given the sweating and heavy breathing?
So the edict that's come out is exercise can be done under strict public health conditions. What does that mean? Well, I have no idea what that means. We just don't know. Right. Can you catch COVID-19 by running in the road by yourself? The answer is no. But remember, we live in a social society. So if you're running on the road, somebody else is going to be running on the road. You haven't seen people for 3 to 4 weeks. You're not going to stop and talk to them. We're human beings. It's our nature to do things like that. So I do believe it is a problem. And there's also going to be a curfew now. So if the curfew is from 8 o'clock in the evening to 5 o'clock in the morning, you're not going to go before 5 o'clock in the morning for a run. And then you're not going to be able to not see anybody. But I guarantee you, we're going to get a mass production of new runners developing and new walkers and new joggers developing in the next few weeks due to this new level 4.
Right. As people are allowed, so they suddenly become runners. But what you're really saying is, in terms of the regulations, you're saying we don't know that yet. We're going to see what happens, but please be guided by that, because they generally have been fairly reasonable.
And they'll give us the answers to say how far, how many people.
Right, but medically, in terms of Danny's question...
so from my personal point of view, I believe that if you are allowed to run with 2 people, you still shouldn't run right next to each other. Stagger together, so run in 1.5 meters together. If you do cough to the opposite direction. If you do sneeze to the opposite direction. You still got to protect yourself. You still got to have hand hygiene, social distancing, and look after yourself.
Right. Okay. Peter wants to know, and I thought this is quite an interesting question. I've thought about this as well. Does washing with sanitizer protect your hand forward or only backwards? In other words, if I put on hand sanitizer and it's on my hands and then I go and press a lift button, will I have some measure of protection?
Some, but not total. And that's why you've got to put more hand sanitizer on afterwards. It's a double-edged sword. You've got to use it. You can't not use it. It does protect you, but then you're re-exposing yourself. So therefore, you've got to wash it off with the soap and water or the alcohol rubs.
Right. Andrea wants to know, I'd like to know of the deaths in South Africa, ages, genders, underlying medical issues they've had. I feel like there's no guidelines on how they got infected. Was it at work? Was it at shopping center? I think it's an interesting question in the sense that I don't expect you to answer the question, but how much information should we as a layperson be acquiring? Because we're all making ourselves a little mad.
So that's a very important point. And there's something called the Poppy Act in South Africa, where you've got to protect the population, the people, and giving out, disclosing personal things and keep their privacy issues. So if you go into the Department of Health on Twitter, you'll find out how many people in each province have died, etc. They don't need to tell you what they've died with, what their comorbidities are. That goes under the Poppy Act. That's private and personal information. But they are keeping us well informed. They are telling us how many people per province. And the majority of the people that are dying are elderly people with major comorbidities.
Right. Caron wants to know, when can we expect the antibody tests to be available and how accurate are they?
Yeah, so we're waiting for the antibody test. We don't have a definitive answer when they're coming, but the sooner the better. The antibody tests sort of will work according to your IgG and your IgM. Your IgM is your acute response that you get when you get a response to an infection and a virus. That is the antibody that's released within the first 4 to 6 days. And then within 7 days to 14 days, you get the release of the IgG antibody. And that's the antibody we're looking for. And that's why we test after 14 days. It's a very good test, and it's worked out according to what we call a sensitivity and a specificity. And the sensitivity is how good the test is at picking up positive results, and the specificity is how good the test is at picking up negative results. So you obviously want a very high specificity and sensitivity because you don't want false positives and false negatives. So we're waiting with bated breath to see when these antibody tests are going to come out. And I think it's quite an important test in general, because if you look at a place like New York, now, New York epicenter in America, they've had 770,000 tests done with 280,000 people positive. That's a 36% positive test rate. They've got 19 million people in New York. And if you extrapolate that, you can say that there'd probably be about 7 million cases, but they're not. And they've started doing antibody tests in New York, and they've tested 13.9% positive. So 2.7 million% of the population have come back with positive antibodies. So therefore, it's going to take that whole extrapolation of 7 million downwards. And that's how important this antibody test is, because we know then we can start sending these people back to work. The deaths in New York have been about 16,500. So if you take that, and the statisticians can argue with me and take the whole story, but if you take that and extrapolate, then your mortality rate is about 0.6% of people in New York. And of those 0.6%, the comorbidities and the elderly are far more at risk. If you look at something like the flu, the morbidity rate is about 0.1%. So it's a very good question, and it's a very good test, and we need the antibody tests, but we still need to upscale our tests for positive and negative results.
Right. So the advantage of that is it actually is the one way that we will get the true data around this disease.
100%. You know, people speak a lot about this herd immunity. Okay. You know, people are still asking that question.
Yes, Alona Badi is asking that question as well. Yeah.
Okay. So now, if you look at a country like Italy, for say, okay, Italy has got 195,000 cases with 26,000 deaths. That means and after the testing, they've now got a herd immunity of about 10 to 15%. 10 to 15% with 26,000 deaths. If you extrapolate that, you need about 70 to 80% of people to get infected with the virus to get a herd immunity. So the herd immunity theory is only going to hold water properly when we get the vaccination. The vaccination will give us 80 to 90% immunity. But you've got to send people back to work. You've got to get the economy going again. You've got to keep the social distancing. You've got to do these things. And that's why also, once again, this antibody test is so important.
Peter is asking and talking about going back to work. We'll talk about this in more detail, but if you can just answer the question, this particular question, when we go back to work in our offices or factories, will we need to wear our masks all day until we get home again?
The answer is yes. If you're in contact with people, the wearing of masks is mandatory. It's now been made mandatory and compulsory by the government. That's how we're going to delay also the spread and stop people co-infecting each other. Everyone thinks we need to co-infect each other. We do not need to co-infect each other. Israel have now taken the approach. They start to send their workforce back, and they are keeping all the elderly at home and over the age of 65 and the comorbidities, and that's right. So if we do send the workforce back, then we want the younger people, the healthier people, to get infected so that they can build up their immunity and antibodies to it. But it doesn't mean there aren't going to be deaths and there aren't going to be people who get sick from it. At the same time, you've still got to wear your mask and protect yourselves, because 20% of the population are asymptomatic. So we don't know that they've got the virus because they've got no symptoms. So yes, you have to wear your mask.
A lot of people are asking about the lockdown and the situation in Sweden. Has that worked? Has that worked better not to lock down a country? There's an article in The Hill as well that a number of people have sent me. Can you talk to that?
So Sweden have currently got 18,000 cases with 2,192 deaths. You're looking at a population of 10 million people, and you're looking at a majority of the population being law-abiding citizens. But what people don't know, and what they're not telling people, is the majority of the population have taken to voluntary social distancing. That means they're not using public transport. That means they are doing voluntary social distancing on their own accord. The government has banned community gatherings of more than 50 people, and they've banned visitation to old age homes. Yet with this so-called no lockdown, they're still in the top 20 countries in the world for the amount of virus affectation. They've got a higher death rate in relation to their population size than anywhere else in Scandinavia. So is it working? I don't believe it is working. But are they not doing lockdown? They are doing lockdown. They're doing their own form of lockdown. They're not disobeying or doing things differently. They may not be all wearing masks, but they all are taking care and trying to avoid it.
Interesting, interesting indeed. A number of people are asking also, is there evidence that the virus can be transmitted through food?
So we have discussed this before, and the answer is most unlikely.
Right, okay. Tanya wants to know, as well as Prasanta, does the virus end in your body, or does it wear out over time? Or does it? I don't really.
Yeah, I think I understand what they're saying. If you look at something like influenza, it's called a seasonal virus. It comes in winter, and people get affected to it. And you look at this coronavirus, this SARS-CoV virus 2, and although the northern hemisphere is now going into summer, we're still seeing cases. So we can't call it a seasonal virus at this point in time.
Right. Okay.
People who are getting affected by it are starting to develop antibodies. And that's what that antibody test is showing us. So does it burn out? Do your antibodies destroy it? We hope so, and we think so. But remember, it's still called a novel coronavirus. It's a new virus. We still don't have enough information to answer all of these questions with great success.
Right. So Suzanne wants to know, when is it acceptable for grandparents to see grandchildren? This is a very painful subject for a lot of people.
Unfortunately, even in level 4, it's still not acceptable to see grandchildren at this point in time. We are still, I think people got to understand, level 4 is still lockdown. Yes, there have been some easing of some of the restrictions, but we are still on a lockdown. So you can't have play dates, and you can't do any of your social parties and connections with people. So at this point in time, at level 4, it is still, you're still unable to go and take your grandkids to their grandparents, unfortunately.
Right. Unsigned wants to know, surely that all this washing of hands, sterilizing our groceries, not getting out, is stripping ourselves and our kids of immunity, and therefore risks making this situation worse.
So remember what we've said. Okay, the whole purpose of the lockdown now has been a self-defense mechanism, and it's a self-defense mechanism for the hospitals. And this has allowed us to get ready for this pandemic. It's allowed us to learn routines, how to do things, how to separate certain wards, and get ourselves ready so that when the virus does hit, we've got all these protocols in place. We are going to start getting people going out more often, and people are going to get affected. But those are getting affected, we are hoping, are the people who don't have the comorbidities, and are the younger people, and are the healthier people. So if they do get sick, a lot of them will be asymptomatic, and they won't be as sick as many people who could potentially be sick. Remember, we think that the vaccine can still take up to 12 months. Right. So we've got to be very careful.
Let's just talk about this whole going back to work or going back into our environment from a sort of a medical psychological perspective, because right now there is no normal. Had we walked into our office wearing a mask and hand sanitizing ourselves in January, people would have been quite concerned about us. Now it's going to be expected, but we don't know, or certainly I don't know, what the measure of normal is. So whereas OCDs must be thriving right now, some of us are actually a little bit worried about our mental health. What is normal and what is not? I walk into my office, I open a door, I press a lift button, I make myself a cup of coffee. At which stage must I be sterilizing my desk? Must I be checked as I walk in for my temperature? What is normal and what isn't normal?
So I think what's normal is there's no normal. But the normal that we're going to be dealing with now is strict criteria still. So if you go to the office, and one thing I've got to say, when I drive to work and I see people driving in their cars wearing masks, I always giggle, and I think it's the funniest thing ever. What do you think you're going to catch coronavirus in your car from yourself? So, in other words, I'm saying to you, you don't need a mask in your car.
You can't be too careful.
You can't be too careful. Unless you've got a passenger in your car, that's a different story. But if you're by yourself in your car, you do not need to wear a mask. You will not get it from the exhaust fumes in your car. So the point is, when you get out your car and you're going to interaction, you put your mask on straight away. And with the right technique, you don't put your hands in front of your mouth. You put it on from behind. You sterilize your hands before and after, so you keep your hands clean. If you're going into the office building, you've got to make sure that if you touch the lift with your finger, and preferably you don't, then you wash your hands or sterilize your hands afterwards. Any office that is working, and we're going to, as the president said, it's going to be at a third of the normal amount of people that are there if they need to be there. You're going to have to set social distancing between desks. So 1.5 to 2 meters between desks. People can't cohabit in boardrooms unless they are separated from 1.5 to 2 meters. You need to have good airflow in the offices. You can't be in a cramped office where people land up coughing, even if they are wearing masks, because some people don't wear their masks correctly. So the mask is put under the nose, which is incorrect, and the mask is loose on the side, so people are coughing, so the germs can still come out from that side. So the new normal for us is going to be going everywhere with masks and hand sanitizer for now. For now is a quantum number at this point in time, because we don't know how long that's going to be.
Yeah. Okay. So, should there be a rule to say, well, if I'm sitting and working at my desk, it's good to sanitize my hand every half an hour?
If you're sitting at your desk and you don't have any exposure to anybody, if you've sanitized your hands and you haven't moved up from your desk, then you don't have to do it every half an hour. But if people are coming to your desk, or you're going from your desk all the time, then yes, you should.
Right. And going back to the other question, you should be wearing the masks at the office.
Unless your door is closed in your office. If your door is closed in your office and you're by yourself, you can take off your mask. But if you've got people in the office with you, you need to be wearing a mask.
One of the questions, if you don't mind me asking, is when you receive a patient that is a patient or person under investigation, or somebody who's COVID positive, what does it mean to you in terms of preparing to engage with that patient?
That's a good question. I think what people have got to understand, when someone comes to the hospital and they're sick enough and need admission, if they've got a cough and a fever, or they come from any old age home, or they've got any symptoms that could be construed as having COVID-19, then they are recognized as what we call a PUI, a person under investigation. Now, the casualties are set up for these type of patients. They've got rooms outside the casualty where the patient is triaged. And from that first point, if the patient is considered to be a PUI, the casualty staff are already dressed up in clothes, protective clothes, to protect them from getting the virus. At that same time, a swab is done. And then the patient is then sent, if needed, to be admitted to one of the PUI wards, which is a person under investigation ward. If the patient is extremely ill and need to go to ICU, then they go to the ICU COVID ward, which has all been set up, and we've had time to set these things up due to the lockdown. Now, what does that entail? So the patient will get to the ward. The patient has to be taken with a mask, with protective clothing for the nurse and for the porter who takes the patient to this PUI ward. The patient gets into the ward, and then the doctor's called to the ward. At the ward, there's dedicated cubicles where the patient is in a private cubicle with their own private sister who's wearing all the mandatory clothing and stays with them for 6 hours before they change over their shift. When the doctor gets there, they've got to go through a whole procedure, which is called donning and doffing. And this is the procedure to protect healthcare workers from getting the virus and from spreading it to other people. It's an extremely complex procedure, and it's best to be done with a buddy. So we generally do it with another nurse that helps us dress and undress. When we get to the ward, we put on protective boots. We then go into the ward and we go to a specific room and get changed into a different set of scrubs. You put on the scrubs. You then go and do the donning procedure, which is putting on the clothes. You put on 2 pairs of boots, you put on 2 pairs of gloves with the help of a sister. You put on a surgical gown, a surgical apron. You put on a neck covering, you put on a head covering. You wear an N95 mask as well as goggles or glasses, and as well as a visor. So it takes quite a long time to get dressed up. And if you're doing it properly, it can take you 15 to 20 minutes to don for the procedure. And that's when you're not at any risk. But you've got to do it correctly so you don't have any breaks in your seals. And your donning partner is watching you and guiding you through the process so that there's no mistakes. You then go into the room and you examine the patient. And when you come out, before you even come out of the room, you've got to do hand sterilization, wash your hands. You take off one layer of the shoes and you take off the apron. And that's done inside the room. But you don't touch the front. You touch it from inside so you don't contaminate yourself. And between each step of doffing, of taking off the clothes, you've got to wash your hands and do it with your buddy and not contaminate yourself. And that also takes 20 to 25 minutes. So every single patient that's coming in that's considered to be a PUI, this is the process we have to go through. Once you've taken off those clothes, you then go and shower and you do yourself in a full Hebe scrub wash. You change back into your normal scrubs and then you leave the ward. But it's quite a complex procedure, and we are protecting everybody in these processes.
Wow, that is unbelievable to listen to. All right, before we wrap it up, a final question. People are asking about vitamins, vitamin C, vitamin D. Give us your view on that.
So Paul Merrick, who's an ICU specialist in the United States, has come up with the use of vitamin C in extremely ill patients and high dose of vitamin C. Remember, vitamin C is an antioxidant. It's very important in the production of things like collagen and carnitine, and it's vital for our immunity and for our immune response. Is it a good idea to take vitamin C on a daily basis? Sure. We need to improve our immunity through the winter season anyway. Vitamin D has a role in what we call our adaptive immunity. So it's got potential for intervention, and it's an immune modulator. And could we be taking vitamin D in low doses throughout the winter period? Yes, we could be. Are we using it for mildly symptomatic COVID-positive patients? Yes, we are. That doesn't mean everybody's got to be on it. But it's a catch-22 because we live in South Africa. And everyone thinks because of the sunlight, you're protected. But you don't go into the sunlight because you're worried about getting a melanoma. So generally, our levels are lower in South Africa. And therefore, you do need to increase your levels of vitamin D.
All right. Dr. Anton Meyberg, we really are out of time. We've gone over, in fact. But all of this was, I think, extremely important. Thank you for all of the work that you do. And thanks for taking the time every Sunday morning to talk to us on the Synthesis podcast. Thanks to Synthesis as well for their sponsoring of this podcast. And we'll be back with you next week for a further update. Be safe.
Looking forward.
Absolutely. Be safe, be healthy, and be kind. I'm Howard Feldman. This has been your Sunday Synthesis podcast.